It's been done, not a lot, but when there's this kind of national crisis. So the NIH decided that they were going to initiate a study of prenatal cocaine exposure. So this is the largest study that has been done. It was done in 4 different sites. I was the principal investigator, and what we did was the main idea was to look at the effects of prenatal exposure on childhood. I keep on doing that. On childhood outcome. So it began in the early 1990s, and we followed the kids out to 16 years. We had, 2 groups, about 1,400 babies, an exposed group and an unexposed group. And what we did here that's a little different is because, as I mentioned, women who use cocaine tend not to use cocaine only. They also use alcohol, marijuana, and tobacco. The way we set up the study was we said, okay, we got one group that we're going to call our cocaine-exposed group, right? And we understand that they're going to also have alcohol, marijuana, tobacco. So our control group, instead of being lily white, unexposed to anything group, of course we're going to find differences there. Our unexposed group was unexposed to cocaine, but exposed to alcohol, marijuana, tobacco, right? So the difference between the 2 groups is the cocaine, because both groups have alcohol, marijuana, tobacco. The inference being that if we find differences, then they're going to be due to the cocaine. So the MLS, maternal lifestyle study, was a multi-site study. It was coordinated at Brown, and then the other sites were University of Tennessee at Memphis, Wayne State, and University of Miami. And just to give you, this is just a summary, hundreds and thousands or whatever, at least 2 publications that came out of this, but just to give you an overall summary of the kinds of findings that came out of the study. We found lower IQ and language scores. This is all related to prenatal cocaine exposure. More what are called externalizing problems. So this is things like acting out, delinquency, impulsivity. More psychopathology, ADHD, conduct disorder, depression. There were more special education referrals. Now this is one that I kind of hinted at before. The kids who were cocaine exposed, the onset of their substance use was earlier than the non-exposed group. So they started using, not cocaine, but they started using what are called gateway drugs, alcohol, tobacco, marijuana, earlier than the unexposed group. And by early, I mean as early as age 7. And so the whole progression started earlier in the cocaine-exposed group. So again, that brings up the issue, are we talking about the rearing environment, or are we talking about genetics, or are we talking about both? There's always been the concern about sexual issues with these children, and yes, there was more sexual contact at an earlier age in the cocaine-exposed kids, more unprotected sexual intercourse in boys, and there were a couple of studies of neuroimaging, structural, functional, that were all related to cocaine. So this is all true. I mean, these are all documented findings, and they're all, again, let's say pure cocaine exposed findings. But the findings are subtle, right? they're not the kind of huge deficits that were originally feared. So again, let's take an example. And you know, for me, this hits home because I get a lot of calls from, you know, parents around the country who say, you know, I'm thinking of adopting a cocaine-exposed baby or an methamphetamine-exposed baby. What am I in for? You know, what am I looking at here? What are the odds? What are the risks that something's going to be wrong with this baby? And obviously that's a very sensitive issue, but in many ways, because they say, you know, I looked at the literature and it talks about all of these deficits, but you know, what kinds of deficits are we talking about? And more important for these parents, you know, there's this concept in at least the developmental literature called goodness of fit, which means that a lot of development has to do with the relative fit between what the baby is like and what the parents want or like or are willing to tolerate, right? So, example, let's say you have a baby who is particularly cranky, irritable, maybe even colicky, and the parents can't stand it. That's just them. I mean, you know, I mean, some people have more tolerance for irritable babies than others, right? So you have the combination of an irritable baby and a parent with a low tolerance. That's a misfit. That's going to be trouble. And is Paula here? Okay. You may hear about this more later from, but this is what comes under the field of mental infant health, where you're really looking at the dyadic relationship. So when there's this kind of misfit, you're more likely to have problems in the mother-infant relationship. If, however, you have an irritable baby and the parents aren't particularly freaked out about it, then that's not a misfit, okay? And I'll give you just kind of the opposite clinical case study. We had a baby who came into clinic once who, this was a 4-month-old, beautiful, I mean beautiful, blue-eyed, you know, calm Gerber baby. I mean, everybody's fantasy baby, right? And then, you know, mom brings the kid in and you know, we're looking at the kid and trying to figure out why she's here, right? And, you know, she said to us that she was worried about the baby. And we say, okay, you know, why? She says, he just sits there. He's like a vegetable. He doesn't do anything, you know? I'm worried that he's brain damaged, right? So this was a case where the mom wanted a jazzy boy. She wanted a kid who was, you know, going to be jazzed around and you know, more active. And she got, instead, what she thought was a vegetable, right? So again, that's a mismatch kind of in the other direction. So this is a long way around kind of saying that when you're working with these parents who are talking about adopting an exposed baby, a lot of it has to do with, well, what are you willing to tolerate? What's your threshold, right? You know, are you willing to have a baby who may wind up with CP? Is that within your bailiwick? I mean, and you know, so again, those are the things that you really have to help these parents work through. Are you willing to have a kid who has a reasonable chance of having ADHD? Oh, that's a different story, right? If you're looking for the perfect kid, you know, can't give you that kind of guarantee, right? I mean, I know, you know, we know the environment is critical. We know you're going to bring this kid up in a terrific environment, you know, but that's not a guarantee. So the kinds of effects that we typically see are more in the, ADHD realm. And I can't guarantee you that. There's certainly going to be some kids who do have CP, but the odds are what we're dealing with is this mid-range, let's say. If the kid's going to have a deficit, odds are it's going to be in this kind of range, okay? And then they really have to work through and say, is this acceptable to us as parents, right? And then it's, it's really up to them to try and work it out. But that is more or less what we're talking about in terms of the kinds of deficits that we see. And even when we see things like externalizing problems and conduct disorder, yes, we see these things. They're, people would say, well, how often do they occur? 10% maybe, okay? So, okay, you have a 10% chance of the kid having some relatively serious psychopathology. But some of these kids, they do have acting out problems, but they're not they don't reach clinical levels. They may be borderline clinical significance, but they don't fall into the realm of clinical diagnosis, which is not to say that they're not difficult, but again, you just got to understand what level that you're dealing with.
Dr. Lester, can I ask a quick question? Just to clarify, I'm going to read your article on the subtle findings because I think that's going to help you a lot. But I'm just wondering, and you kind of touched on it, when you say subtle, is that per factor or overall all of them are subtle? Because I'm sort of wondering if they tend to show more clusters of the behaviors which end up being significant.
I see what you... I would say, well, if you break the world down into, cognitive, intellectual versus behavioral, I would say the findings tend to be more in the behavioral domains than in the cognitive domains. Yeah.
Thank you.
And that, that's interesting too, because, as a society, we're much more concerned, not that we should be, but we're much more concerned about IQ kinds of cognitive findings than we are about, behavioral findings. I mean, that's just a tradition that's ingrained in our society. I mean, I remember lots of times, you give talks and the first thing everybody wants to know is, what about IQ? What about executive function? Like, that's the sine qua non. I mean, that's really where the money is. Which, again, not that it's not important, but economically, if for no other reason, you could argue that the impact of delinquency and theft and incarceration and is going to have a lot bigger effect on society than some kind of mild retardation, which again is more localized to an individual, but that's kind of another debate. So you look at these findings and then you have to say, but, right, caution, 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 these findings have to be understood in the context of the postnatal child rearing environment. And this is kind of, again, what I said before, that the drugs alone typically are not sufficient to produce deficits. Typically, it's the combination of the drug exposure in the context of various other environmental factors, again, which may have to do with abuse, with gangs and who you're associated with, and parenting, many factors. And multiple out-of-home placements is certainly one of them. So, again, simple way to summarize this up is that a bad environment can worsen drug effects, and a good environment can overcome drug effects. And part of the reason that this is true is because the most rapid period of brain growth in babies is the last 3 months of gestation and the first couple of years. That's when the maximum brain growth is. And the human brain is incredibly plastic. It's incredibly adaptive. It can overcome deficits. It can recover. And that recovery can be produced by environmental changes, by positive aspects of the environment.
Which is why that 0 to 3 is so important for us to teach all of our caseworkers and everybody else, right, Dr. Lester?
Yeah, exactly. And that's why, there's so much work now on what people call early adversity or environmental toxicity and the stress that goes on in the first couple of years of life, and how if that stress continues and it becomes chronic, how it literally wears and tears on the HPA system and reduces reactivity to later stress, and really good data on long-term effects having to do with cardiovascular disease and metabolic disease and diabetes. I mean, it's a whole field called fetal origins, and again is tied to a lot of the epigenetic work. But even, some of this is even spontaneous. And for those of you that work in a NICU, you know that you might see a baby with an IVH, with a bleed in the brain, and it's right there, and then a couple of days or a couple of weeks later, it's gone, right? The brain heals itself. Cool, right? Well, if we can facilitate that, then we're going to overcome a lot of these deficits. And I'll give you another example of how a good environment can make up for prenatal exposure, and this is a real story. I got a call from Sports Illustrated, right? And they wanted to put this kid on the cover who was a world-class skateboard champion, right? Well, the kid had been prenatal exposed to methamphetamine, and they wanted to write a story about, look, kid's exposed to methamphetamine, and he becomes a world-class skateboarder, and look what this drug can do for you, right? So, they wanted to do a little interview, and I figured, well, this is my only chance to get into Sports Illustrated, right? There's no way I'm going to pass this up. So, I started asking some questions, and oh, yeah, well, the kid was adopted right from birth by his grandparents and brought up in a relatively, middle-class home, an excellent environment, and right? So, so what happens in these cases is, drugs like methamphetamine do tend to make you more, or can make you more, let's say, intense, right? The question is, where do you channel that intensity? Where do you channel that focus, right? And that's one of the things that is always fascinated me and mystified me about this whole area, because you have two kids with the same kind of exposure, and one becomes a delinquent and the other goes to Wall Street. Equal theft, but they just channel it in different directions. So what is it that makes one kid go in one direction and one kid go in another, right? And can you identify, or how early can you identify which of those directions the kids are going to go into? And if you can do that, can you develop interventions, preventions to try and push the kid in the right direction? So, shortly after the cocaine, quote-unquote, epidemic started to die down, and really what happened was the pendulum swung back to the middle, and, we now know, I think, what I just explained to you. Methamphetamine became the next crisis, and so you would see, methamphetamine use plagues rural America. If you track the use of methamphetamine when it started, it started on the East Coast, on the West Coast, and then gradually spread. But the interesting about meth is that it basically, with the exception of here, it basically